from a social work perspective. So let's see here with me for 1 second to get to the correct screen. So in this presentation, we're going to explore the landscape of substance legalization within the U.S. We're going to examine the impact on clinical social work practice using, of course, some insights from your textbook, Dopamine Nation. So let's get into the historical context of substance control. So let's start with the Harrison Narcotics Act of, believe it or not, 1914, which seems like an eternity ago. So this actually marked the first time that the FDA was actually or the federal government was actually regulating drugs. They're really focusing on opioids and cocaine. And what ended up happening was that led to an increase in, of course, criminalization and also, ironically, restricted medical access. This act laid the foundation for future policies that kind of prioritize law enforcement interaction over medical treatment for substance use disorders. And of course, this restriction related to the involvement, I should say, of law enforcement really led to the having individuals having stigmas related to their struggle with addiction, and then of course the negative connotation of growing illicit drugs within the market. So then we're going to fast forward to 1970 and the framework with the Controlled Substances Act. This really established the modern drug scheduling system, so classifying those substances based on medical use. So for example, when we're looking at benzos within the mental health profession, now there are different levels of things. So for example, certain prescribers don't have the authority to prescribe certain medications. Back in the day when it was actually early 2000s when they started to try to control the opioid epidemic a bit more. Physicians even had, depending on the state, they had a limit to the number of scripts that they could write out to patients every month, which was kind of fascinating. So back to the Controlled Substance Act. This act consolidated existing drug laws and created the Drug Enforcement Agency. So that's the administration, my apologies. That's the DEA, which still to this day regulates and enforces substance control. As you guys know, it's been criticized for disproportionately impacting marginalized communities through its strict classification system. So you've got situations where, let's say, there are different populations that maybe don't have great services intact. That's probably one of the unintended consequences of this, of the DEA and the Controlled Substance Act of 1970. So some of the most recent state and policy changes and key milestones include, of course, the legalization of cannabis in multiple states. Although there are still plenty of states that do not have legalization. Currently, I'm in Tennessee, and that is one of the states that that is still criminalized heavily. And also, again, within the last couple of years, the decriminalization of psychedelics. States like Washington and Oregon are just droves ahead of some of the other states within with exploring the really, really good benefits to psychedelics. And then, of course, there are new harm reduction policies continuing to address the opioid epidemic. There are several state-level shifts reflecting growing public support for alternative approaches. So, if, for example, the decriminalization of cannabis and the support of medical, the use of the medical field utilizing cannabis as well as a treatment modality. And then, of course, safe injection sites, which have been around for a while, and needle exchange programs, all that good stuff. Okay, so the last portion of the historical context of substance control focuses on evidence from Portugal's decriminalization model. So Portugal did, they've shown over the last 20 years really good reduction in deaths related to overdose, HIV transmission, and incarceration rates. And what they're doing is they're shifting focus from being punitive to health-based strategies. What a novel idea, right? Let's maybe help the people and not criminalize them. So it's been kind of cool to follow Portugal over the last 20 years or so. If you have the opportunity, if I were you guys, I would do kind of a deep dive, especially if substance is something that you're interested in. Okay, so the neuroscience of addiction, Okay, so let's move forward in the interest of time to the clinical impact on current policies. I guarantee, because I just listened to the recording, can hear my dogs in the background. So I'm a Frenchie mom. The one that sounds like tea kettle, her name is Sophie. And then, of course, Peaches, my old lady, is currently barking because I'm sure that there's a bird or something. So I apologize for the background noise. Okay, so clinical access to treatment. So first of all, treatment access. There are just a ton of barriers to access to some of the more criminalized medications. And there have been states that have just gone through, again, an extraordinary efforts. Some do it much better than others. For example, there are laws that protect people if somebody is overdosing on, let's say, heroin, that if they call the police, then they're not going to be criminalized for that. I'll give you just kind of a personal experience. I have a friend whose daughter was in her early 20s last year, and she was engaging with this person, and she actually overdosed. She started having seizures related to her substance use, and he ended up eventually calling 911. She was in the hospital for a series of weeks and ended up passing away. There are many other layers to the story, but long story short, he was not prosecuted because he did actually call and get the police and medical system involved. So, states that I know have done this, California, Florida, Kentucky, Ohio, and those are some of those are just things I'm thinking of off the top of my head. And those are some of the states that have, access to Narcan and all of that good stuff. So, of course, oh goodness, the stigma related to help, people trying to get help, it really, really impacts, clinical social work and our ability to treat. There's the fear of legal consequences. There's the fear of societal judgment, which deters individuals from seeking treatment. Excuse me. This stigma is really severe for individuals in professional or parental roles. So there's just a significant sense of isolation, specifically in those populations. The criminal justice system intersection is fascinating. It's been fascinating to see that over the last 20 years or so, and how that's kind of shifted a bit. Again, county-specific, state-specific. One of my last students was actually on several social media, national media outlets. He was actually on the national news multiple times, was on 60 Minutes, based on his work that he had done within the state of California in the criminal justice system. But, what we do know is there are high rates of, high incarceration rates for drug-related offenses. And what I see some organizations or some criminal justice systems doing is they're moving toward that treatment modality within the incarceration period. But there are, and as you guys know, drug-related arrests disproportionately affect communities of color, and there's significant exacerbation of systematic inequalities, which can be very frustrating. There are divergent programs and drug courts that have been introduced as an alternative for sentencing, again focusing on rehab rather than incarceration. So there are kind of some really cool statistics that are pretty recent. So we've seen that there are improved recovery rates with integrated care models and harm reduction strategies, which you guys are becoming more familiar with. This research highlights the medical assisted treatment, which you guys have talked about, and then of course comprehensive behavioral interventions, which really honestly can yield better long-term results. We have programs that incorporate peer support, and then of course community-based interventions, such as AA, NA, have proven to show in some individuals reducing those relapse rates, those recidivism rates. Okay. So, moving right along. This presentation is not my friend today. Okay, so next slide is talking about the public health approach versus the criminal justice model. Now, I don't want this presentation to come off as, I'm anti-criminal, using the criminal justice model. I think there are definitely some benefits to that. And I'm sure you've heard, stories where they've said, clients or friends have said, if I weren't in jail, I wouldn't be alive. So, so I'm not saying that that's necessarily a negative thing. But there is really has been for several years, a significant shift with trying to get through, looking at it as a public health epidemic rather than, again, from that handed model. So we've got those harm reduction strategies, again, programs like syringe exchanges, supervised consumption sites, opening homeless shelters to those that are actively using, with of course having medical doctors or nurse practitioners and nurses there as well, really have helped the spread of infectious disease, have helped limited the spread of infectious diseases, and then provide bridges to treatment. When you look at cost comparison, treatment versus incarceration, studies show that treatment is significantly more cost effective than imprisonment. Incarceration costs taxpayers billions of dollars annually, where treatment programs have a higher success rate in reducing recidivism. So, of course, there's impacts on social determinants of health. So addressing those social economic factors is really crucial for sustainable recovery. Things like employment support, housing stability, and then, of course, access to health care for long-term recovery success. And then, of course, there's, again, evidence of, like I was saying, those supervised consumption